Be a savvy consumer of autism services, and what does evidence-based really mean? My name is Matthew Lay, and as always, I will be your host. I'm joined on the desk. It's been just over 7 years since Tracie Linbland was with us. Tracie, thanks so much for coming back.
Thanks for having me.
Very topical or a very important topic, as we've been talking about the changes in legislation that all of you are all too familiar with. So in this presentation, we're going to look to assist caregivers in understanding how to determine if services are evidence-based, and we're going to look at a wide range of services. But before we get to that, let me remind you, a big part of my job is to get your questions answered. Submit your questions using the Ask Question box. They will be funneled to me on this iPad, and I will do my best to get Tracie to answer them for you. From time to time, I am going to be referencing a list of resources. The Resource Center is packed today with information that helps to inform our discussion, so you can go ahead and check out some of those. I'll be talking about them. And if you have any issues throughout, click the Help button, and you will get assistance. All right, with all that out of the way, let's get started. So Tracie, talk to me about what we're going to be discussing today and why it's so important at this point.
We're going to be discussing some services that parents may come across for children with autism spectrum disorder, children and youth, and how to make really good decisions about those services.
Okay.
So what does the research say? What does the evidence say? What works for your family? And what to basically look for in terms of services to make good decisions.
And one of the promises was that we're going to look at what evidence-based really means. It's a term that gets thrown around a lot on this desk and everywhere, but to level set for our audience, what does evidence-based mean?
So evidence-based, there's a couple components to evidence-based, and I agree, it gets misused often, it gets used often, and people are really struggle with that, and it carries weight, and so I think it's important to really understand what it means. So evidence-based practice is a process.
Right.
It's a process that you follow in order to determine if you're getting the desired outcomes from whatever you're doing.
Okay.
And so part of evidence-based process is that you need to take into account the strongest level of empirical evidence or scientific evidence that's already published.
Right.
So that's one thing. You need to have a clinician or a therapist or a professional who has competency and skill in that area or with that technique.
Right.
So second. And the third is the person themselves or their caregivers and what do they want. And so you actually have to marry those three things, but the biggest thing that you have to take into account is what does the scientific evidence say about what you're going to do. So things can't have evidence-based practice. So an iPad or an AAC device does not have evidence-based practice. It may have empirical or scientific support, but it's the way you put it into practice that makes it evidence-based.
Parents are having to make these just difficult decisions right now, and they're not going to go out and get as many letters behind their name as you have today, which is I think part of the issue. But we're going to help navigate that. So today we are going to talk about some of the services that are available. What are the services that we're going to talk about today?
Right. We're going to talk about services that are typically those that parents with children with ASD look for.
Okay.
And the ones that actually have evidence to date. So the services that have evidence are applied behavior analysis.
Right.
Educational services. So there are some types of educational programs that have evidence.
Yeah.
Medical services such as pharmacology or medications.
Yes.
Some have some emerging evidence. Occupational therapy. Psychological services, and I'm not going to speak on that one today, but there are some things that have quite a bit of evidence as well, and then speech-language pathology services. Okay.
And we see the three that we're going to talk about today, and I didn't want to go into your background, but you have, your background is in ABA, as well as speech pathology, correct?
Correct, yes.
So where do you sit now? What are you doing every day?
Every day, what do I do? I'm the clinical director of a company called Monarch House.
Right.
And it's an interdisciplinary treatment center, and I'm the clinical director for Ontario and Eastern Canada. So we have a number of different centers, and we offer a host of different services, and ABA is one of those, occupational therapy is another one, speech pathology is another one, and we have some psychology services for diagnosis. So I oversee the clinical services in those areas as well. Like you said, I'm a behavior analyst, a board-certified behavior analyst, and a speech-language pathologist.
Okay, so clearly that is why you've been invited to the desk today. So let's start with ABA. So what is ABA? Okay,
I think the very first thing that is what is ABA not? So ABA is not a therapy.
Right.
It's actually not a treatment, a specific treatment. ABA is a scientific field of study.
Okay.
And so it's very broad.
Right.
And it is applied to much more than just autism.
Yes.
And I think that's where people have some trouble understanding it. They say, like, I'm getting ABA therapy. You're actually getting applied behavior analysis, and it's about principles of behavior. And so it's a scientific field that looks at analyzing behavior, observing behavior, assessing behavior, and then putting into practice some principles or kind of laws of behavior that we know exist for people,
right,
and changing that behavior. What it doesn't do, ABA, what the field is not set up to do is fundamentally change someone's personality, to intervene on behaviors that aren't interfering with their functioning. So it really is about good learning, good teaching, and getting a person to be able to achieve their optimal outcome.
Okay. Okay, but so you said it's not therapy, but it needs to be delivered by a professional, correct?
Mm-hmm. It needs to be delivered by a professional, and that's a bit of a problem right now in Ontario.
Okay.
Because the field is not regulated here.
Okay.
And so right now, anyone can call themselves a behavior analyst or a behavior therapist or a behavior consultant without any type of training or credentialing. And so it's, the field itself is internationally recognized. It has a credentialing body from the United States. And the credentialing body gives out 3 different credentials, actually more than those 3, but the top 3 that we see in Ontario is board-certified behavior analyst,
okay,
which is a master's level clinician with 2,000 supervised hours. They write an exam, and so it's a minimum entry level to practice, much like speech pathology or occupational therapy. The second level is a board-certified assistant behavior analyst.
Okay.
So again, they have to go through coursework, supervised practice, an exam, and they have to be ongoing supervised by a behavior analyst for a stipulated amount of time. And then the bottom level is the frontline worker, which is a registered behavior technician. And again, they have to go through coursework and be supervised in practice and write an exam, and then ongoing weekly supervision. And so those are the 3 that you typically will, what are best to look for in Ontario right now until we get regulated.
And we are getting regulated.
We are getting regulated.
Okay.
The government has said that they will regulate the field of behavior analysis in Ontario, which is very welcome. We all do welcome that. It will afford another measure of assurance for families.
Right.
That the person that they're looking for has actually met these minimum standards.
Yeah.
And as well, there will be a complaints process and a body that oversees complaints. Right now, there is a complaints process with the BCBA. It's just a bit difficult. You know, it's not the same.
So the government's recognized it, and so we have a question that's already come in, and that question is, you say that there are those who are not board certified or in any of these classes, and they could be delivering ABA or calling themselves behavioral analysts. What are the risks of working with someone like that who's potentially not on this list of accreditations?
Right. So the risk is that they actually don't understand what they're doing or not educated to the level that they need to be. And when you're shaping up behavior or you're dealing with severe problem behavior or different areas of functioning that actually, you know, if you didn't do treatment right, you could get a lot of harm. So feeding therapy, toilet training, all of those things, teaching language, teaching communication. If you actually aren't really up on your game and don't know the best techniques, then there's things that you could be doing that are really difficult to undo. Mm-hmm. Not only that, you have nowhere to lodge a complaint at all if something happens. And you may be spending your time, your money, good resources, your child's time, going down a road that isn't helpful when you actually could have been getting different therapy that would be helpful for the long term.
I mean, you wouldn't go see a dentist
wasn't licensed.
Right. I mean, it's the same thing, but
same.
with parents being so desperate sometimes for care, I could see how this can occur. Before we move on, I can take one more question from our audience, which is going to lead us well. I love when they ask questions that help lead us into what it is we're about to do. But this question is ABA only good for young children? My nephew is 13 and has just been diagnosed.
Right, perfect question. So ABA is good from infancy to geriatrics and death. I mean, that is the span of ABA.
Yeah.
I think what people don't understand is that ABA is not just for autism. And so we use ABA, the field of ABA gets into different areas like addictions, so deals with adults mainly all the time. For dementia, and that's like the geriatrics. Sports, elite sports, we were talking about this earlier. So no, ABA changes behaviors. ABA is used in big organizations to shape workers' behavior. So it is absolutely applicable to individuals who are, over 6 years of age.
Right.
Does the research support intensive ABA over 6? There's research being done right now, not as strong as research supporting children under age of 6 with ASD. But definitely we know that ABA does work to change behaviors for anybody.
Right. First time I learned about ABA was from you, seven and a half years ago, but since then it's been a topic that's come up many times on this desk with many different professionals. And I think that if anyone goes to the resource section and checks out the if you're new to the idea of ABA and you check out the autism-focused intervention resources modules, you'll see some modules that are in practice and are used. And what you'll recognize is that this is good for, as you mentioned, elite athletes, addictions, but this is good for any parent at any point in time. So you'll recognize that at any age, we think this does make sense. Okay, so when we start looking at the services that are available, there is focused ABA and there is comprehensive, also referred to a lot as EIBI. What is the difference between these two?
Okay, and there's a lot of terms, and the government, our program in the last 20 years in Ontario has changed. The names have changed. What we call it has changed. So I appreciate that it can be really confusing.
Right.
So right now we're trying to standardize it to what the Behavior Analytics Certification Board in the U.S., which is the overseeing credentialing body, call it. And it really is two types or two groups for, especially for ASD services. One is focused ABA, which means it's between about 15 and 25 hours, so less hours.
Right. That's a week?
Per week.
Per week, okay.
Per week. A very narrow, more narrow scope that you're going to intervene on, so maybe a couple goals only. And so you're going to focus your time and focus your ABA into just working on those particular things. So not a full curriculum, very narrow. Comprehensive ABA is the other one, and I think that's the one people are most familiar with nowadays. So the comprehensive ABA...
It's the one they most want.
They most want to, yes. Comprehensive ABA, or can be called EIBI, so Early Intensive Behavior Intervention, or IBI, Intensive Behavior Intervention, which was what it was previously called in Ontario. Those are terms that are used in the industry, used in field, used in research. They are used worldwide. So I know that there was confusion earlier that the government made up those terms for the Ontario program, not exactly correct. So people anywhere in the world understand EIBI and IBI as terms as well, but they're really called comprehensive ABA to describe. You're getting a comprehensive program, many, many different areas of functioning you're working on. You're going to have 25 plus hours per week. And so it's a very intensive, repetitive program that really looks at changing the whole child. So we're looking at visual skills, motor skills, speech, language, communication, daily living skills, so like eating, toileting, printing, riding your bike, getting dressed, so a wide variety of things.
All the challenges that these parents are facing. So, I mean, clearly with the early intervention moniker, parents are right that if possible, this is after diagnosis at a young age, comprehensive is the ideal scenario. Is there a place where focused is ideal?
Yeah, focused is ideal if your child is actually not so severely impacted. So whether if they have lower needs. So you might want to just work on if feeding is an issue. So they have a really restricted number of foods they'll eat. You may just need to work on that. Or you may just need social skills training. And so you're going to just work in those areas that are really impacted. Or adolescence sometimes, your child is doing very well, but then they're starting to get maybe anxiety or depression. So then you can use focused ABA and just work on those areas. Also, the other time we see it very useful is if your child has had 2 to 3 years of comprehensive ABA, and then you've worked on a lot of things. They've already made a lot of progress. Then you want to actually just work on those few things that are still left, that may be barriers to being fully included in school or barriers to going out to a big community event. And so you're going to focus your program, tailor it to a more narrow scope.
Is your goal as a practitioner, when you were not running the whole show, to move someone from comprehensive to focus? Is that an actual, is that a treatment path?
Yes, that's a treatment path. So our goal with every child is to make them not need ABA.
Right.
To actually be in their typical environment with peers. That is the goal. So we typically start with comprehensive ABA if the assessment deems that that's what they need. Some kids start at focused. Some kids start already just needing social skills or some communication skills. But typically, when we get them really young, we'll do comprehensive ABA for a prescribed period of time, and we will move them into focused ABA, and then hopefully we move them into a school placement.
Right.
When they're that age.
I'd like to see you tap dance this one. It's going to be a hard question for you to answer because you don't know the child, but I think you might have given it right there. In a parent support group, someone mentioned that their child is getting 30 hours a week of ABA. My child is receiving only 12 hours per week. Should I be advocating for more hours?
So it depends on the assessment.
I knew.
Depends on the assessment.
Right.
I mean, as a clinician, as any clinician should, you need to do an assessment, a comprehensive assessment, to see where those skills are.
Right.
You need to see if there may be problem behavior, and so you may require more. If there's no problem behavior and there's only a few goals that you need to work on, you don't require comprehensive ABA.
Yeah.
It really should come from the behavior analyst who does the assessment to recommend the appropriate number of hours for treatment.
And I think that, people are seeing the power of IBI and they're hearing about it, and so parents are gravitating right towards that. So there's a number of, you call them marketed programs. So there's things that they're going to hear about. Talk to us, what are these various programs that are out there? So
these are the common programs or the common marketed terms that you're going to see in the field of ABA.
Yeah.
These all have evidence, scientific support behind them at different levels. Not all of them have robust support, but they're definitely well researched or in progress. So discrete trial teaching, people used to think that ABA meant this. Just DTT is the other term that people hear.
Yes.
Meaning you sit at a desk, someone gives you a command or an instruction, you have to follow through, and then you get something you like, a reinforcer. So that, yes, it's part of ABA, and it could be part of your ABA program when it's required. But more often now, the early intensive behavioral intervention is more of a naturalistic approach or a developmental approach.
Okay.
So it looks more like play-based therapy.
Right.
So the child shouldn't be sitting at a desk for 25 or more hours a week to begin with, and they should not know that they're getting treatment.
Yeah.
It should be fun. It should be they want to go there, they want to see their therapist, they're having a lot of fun. The therapist has all of the goals that they know they need to meet. They're taking data on it. So that's what it looks like. Verbal behavior is a subset of ABA where it says verbal behavior and parents think that means speaking. It doesn't mean that in the field of ABA. It means you're working on a certain set of skills that will lead to better language and communication, but it could be through assistive devices, so AAC, sign language, pictures, so it doesn't mean spoken.
Okay.
Pivotal response therapy is another marketed treatment that looks at increasing joint attention, increasing language and communication skills. Precision teaching is typically used to increase fluency in skills, or you're kind of being automatic, and higher functioning, more language and communication skills. There's some companies around Toronto that actually offer precision teaching.
Okay.
Direct instruction is more educational. So those are educational programs that are used throughout the U.S. More than in Canada, that have quite a large evidence base. And there are things called reading mastery is one, language for learning is another one, language for spelling and writing. And so they're really about teaching those pre-academics and academic skills. Yep. And then the last two, acceptance and commitment therapy and cognitive behavior therapy, are typically more in the psychology realm, and you would have to have kind of scope of practice and competency in those, but they really deal more with the mindfulness and if your child is having trouble with anxiety and depression and things like that, yep. That they can be really helpful, but there are prerequisite skills that the individual has to show in order to benefit most from those.
You started this by telling us that all of these are evidence-based, but there's a lot of different things within autism that people are going to be hearing about. So one of the resources that you gave us to look at is the is the National Clearinghouse on Autism Evidence and Practice. And this allows, if there's a recommendation that's come forward, it would allow parents and caregivers to go and take a look and see basically what the evidence states, right, on any of these programs. But these are all ones that that have that behind it. So what does ABA actually, what does it look like in practice?
So in practice, it can look a number of different ways.
Okay.
So it can look at one-to-one, that
yep.
you have the child, or the student and the therapist. It can be dyads, which are 2 children to a therapist, or triads, 3 children to a therapist, or small and large group. Okay. So ABA, you can't tell by just looking at the constellation if you're having ABA or not, or if ABA is being used. It can be in a really prescriptive at a table, or it can be out in the natural environment. So out at a show, out at the park, in your community, or it can take place at home. ABA can also take place in schools. So in Ontario right now, I know that the Ministry of Education is also working at and looking at ABA in their school systems. There are private schools that are ABA schools in Ontario, not everywhere.
Yes.
So it's difficult for some families to find them. But ABA works really well. ABA is a technology to teach.
Yes.
So it's just really good teaching where you can analyze errors, change what you're doing so that the individual can learn. And so the other part about ABA is that there's quite a bit of literature to suggest that mediator training, meaning I'm going to teach you as the parent to do this with your child, or you as the teacher or the teaching assistant or educational assistant, and I'm going to supervise what you're doing, and you're going to get good outcomes. So you don't need the behavior analyst or the registered behavior technician to do all of the teaching.
Interesting. This is a good point to answer this question that came in from the audience. I've heard that each child should have clinical oversight. How often should we be meeting with the BCBA? So
there's recommendations, practice guidelines
yep.
from the Behavior Analytics Certification Board that suggests that you need a minimum of 2 hours a week
okay.
of BCBA supervision, or it can be delegated to a BCABA, yep. that assistant, and that for programs that are programs over 20 hours a week, so 20 hours a week and more, then it needs to be a minimum 10% to 20% of supervision. So it's quite a lot of supervision, but you have to think that, in a 20-hour-a-week program, you're amassing huge amounts of data.
Right.
You're really trying to make, push that child along in their learning trajectory, and there are things that go wrong, not from anyone doing anything, just because your child is unique,
yep.
and we have to figure out how they learn. And so the person that does that is the behavior analyst. So they have to be looking at the data weekly, making decisions about how the teaching is going, supervise the frontline therapist, maybe shape their skills, and maybe tweak the programs. So it really is about having those people. The more oversight, the better. There have been a number of studies that have shown that the outcomes are dependent on the amount of supervision that child receives.
There's a question here. We talked about the frontline therapist, and you used a single. This question is ABA as effective if the child is seeing a different therapist every week when they go in? Do you think it needs to be the same professional? So
typically, how programs work, and most of the center-based programs and home-based programs across North America, It depends how many hours a week you have.
Right.
It's always best to have a couple therapists. And if you're having a 30-hour-a-week program, you're probably going to have 3 to 4 therapists. And with any type of program where technology or the implementation of it is critical, you don't want too few, because then there's not generalization opportunities. If that person's sick, then you're missing therapy.
Yep.
But you don't want too many, because then you're having to make sure that whole group of people are functioning the very same way. It isn't typical if the therapist changes every week. You would like your team to stay intact as much as possible.
Okay.
Yeah.
So let's get into something that we all know based on these questions. We're going to get back to your questions, don't worry. But they're hard to find.
They're hard to find. We have 1,000 behavior analysts in Ontario currently, BCBAs, but that's still not enough. And again, I said there's no regulation right now in the field in Ontario, so there's no title protection, meaning if someone calls themselves a behavior analyst, unless they're a BCBA, you have no idea what their background is. So there's a couple things that parents can do to make sure to vet, you know, who do I get, who do I contact. One is to go to the Autism Ontario provider listing.
Right.
That listing is actually a listing where the people, the behavior analysts that are registered on that listing have been vetted.
Right.
So their credentials have been checked. When they graduated, have been checked. They are who they say they are. They have liability insurance and the things that you need to worry about. The other place you can go directly, the public can go to the Behavior Analyst Certification Board and look up, and you can search by province.
Okay.
So you can search Ontario, where are all my behavior analysts, and you can see on there who and which levels. So whether they're BCBA, BCABA, and you can also search for frontline therapists. RBTs are listed on that website as well.
And if BCBA and some of these words and these alphabet acronyms are new to you, and this whole process is, if you have any issues with these, Autism Ontario has a service. It is the Autism Ontario Service Navigator role, where there are individuals that they have that assist you in just, you know, going through and finding the providers, and they're a great place to start if you are struggling at all with this process. Parents now have to be accountants. They got to get the best value for those dollars that they're getting from the government. What do ABA services cost? What does it look like? So
right now, ABA services, there's no fees right now set in Ontario by any specific body because we're not regulated.
Okay.
Saying that, though, it's a master's level clinical practice, so
Right.
it should align with other master's level clinical practice. So much the same as a master's level speech pathologist or occupational therapist. So what the fees are being charged should pretty well align to that. You have to take into account the person's education, how many years of experience they have,
Right.
Where they're working. I mean, there's all different things that factor into what someone charges for their services.
Okay.
But typically right now the fee range for behavior analysts are between $120 and about $250 an hour.
Okay.
If you have a behavior analyst that also is a psychologist or also is a speech pathologist or an occupational therapist, then typically you're going to pay a bit more because you're getting 2 scopes of practice
Right.
in that person.
2 for 1.
2 for 1. BCABA, or sometimes what we refer to as a lead therapist, so people in their masters, but they're not fully credentialed, but they're in their masters of ABA. They charge anywhere from about $60 to $75 an hour.
Okay.
The RBTs, $45 to $55, and an ABA therapist would be lower because
Right.
they don't have credentials. There are also additional charges that parents need to be aware of, and if you've had private speech therapy or OT, you may know this already, that there's charges for cancellations because these are people that are are privately employed.
Right.
And so if you cancel, then there may be still therapists that we're paying,
Right.
if we're running a center. Travel time, mileage, other services, charting, graphing, things that you need to do for your job, and those things are charged by other professions as well. They may be built into the fee. In speech pathology, I'll talk about that a bit, how sometimes it looks. And again, a parent may be saying, wait, my person charges X, and they may very well charge X. It's an open market right now. These fees that I've quoted on here are most of what are reimbursed by insurance companies in the U.S. So
Okay.
they're kind of approved fees all
Right.
throughout the U.S. And they fall somewhat in line with SLP and OT fees as well.
Okay. So $120 to $250 an hour, depending. We have a parent here who has an 11-year-old son with very high needs. With only $5,000 in funding, is there any other way to receive comprehensive ABA? Because that $5,000, I can't do the mental math on it, but it's not going to cover that.
No, $5,000 will get you an hour a week, if that. It's difficult. It's really difficult. What parents are doing is they're getting the training themselves.
Yeah.
So they're going to, become RBTs, or I know parents who've enrolled in the Masters of ABA program because that is the only way they feel they're going to be able to actually get help for their children. For $5,000 a year, if your child actually has intensive needs, then it's going to be really difficult to actually get any type of therapy that's going to be really effective.
Yeah.
Because I'm imagining, and I could be wrong, but if they're saying that there are high needs, that there are real behavior problems as well that are barriers to learning. And so you're going to need some intensity to work on those behaviors first. Other than moving outside of the country, pretty well, I at this point, I can't. There's nothing. This is the hard conversation right now in Ontario.
But it has to be said. That question has to be asked by somebody, and it has to be answered, right? It's needed, and it is a challenge, and we are making progress.
We are.
We are making progress, and unfortunately, it's a hard question to answer for somebody.
Yeah.
So what I'm going to do then is move on to our next topic, which is occupational therapy. So OTs, they're out. They do work in all kinds of places. What is the role of OTs within? What is occupational therapy, and what is the role within autism?
Right. So occupational therapists work on functional skills and mainly motor skills.
Right.
And it really is to help people learn a new way of doing something or regain a skill or develop a new one. So they work on that. They use materials and equipment often that make life easier for the individual. And they adapt the environment to better suit that individual. So our occupational therapists will work on things like printing skills, riding a bike, dressing and undressing. So like fine motor skills to really get the child independent and able to function better with their body.
Right.
And their physiotherapists are related. But it's mainly occupational therapists that we use in ASD.
And once again, these are accredited professionals.
Yes. So they're regulated in Ontario by the College of Occupational Therapists of Ontario. They have a master's level typically. There's also a level of an assistant, so the occupational therapy assistant, which can be delegated tasks by the occupational therapist and supervised by the occupational therapist.
Okay. And OT generally delivered one-on-one?
Generally delivered one-on-one, but there are OT groups. Okay. So there could be like a printing or writing group.
Makes sense.
Things like that, or like if you're trying to learn a specific skill, I don't know, bike riding. Yep. Our OT sometimes has a couple kids at a time she's working with. So it can be groups. It's generally lower intensity services, so about 1 to 3 hours a week, which has been pretty well the norm across Canada, actually, but in Ontario, because occupational therapy isn't generally funded.
Okay.
So in people's extended health benefits, generally doesn't cover occupational therapy. So that hasn't been a widely used service up to this point. Yeah. And now in the brand new childhood budgets, you can use your $5,000 or $20,000 for occupational therapy. So it'll be interesting to see in the field if there is new evidence or research to say that more intensity is more helpful. Right now, there isn't a lot of research in that area.
What's your personal opinion about it?
Oh, occupational therapy. We couldn't do without our occupational therapists. I mean, they know physiology. Right. They know muscles. They know how to get some goals met that we're struggling with. It's not in my scope of practice to know all that. And so, they're a valued team member.
So again, there's some marketed programs. There's some programs that our parents are going to hear about. What do these look like?
So there's a few. There's not so many marketed programs in occupational therapy as there are in other fields, but sensory integration is a big one. It's highly controversial. It is developed by Gene Ayers, and it's a strict manualized program. And so I think there's things like sensory diets and things that are offshoots of sensory integration.
For those who don't know, you said it was controversial. What does it look like? Like, what is it? Why is it controversial?
It's controversial because there hasn't been evidence to suggest that it's really effective.
Okay.
And so there's a lot of things that are being done with sensory integration and sensory diets and weighted vests and weighted blankets and balls, stabilization balls, and things like that. And the evidence to date does not indicate that it is helpful in the majority of clients. And so what you really need to do is check then that if an occupational therapist is saying that your son or daughter requires some sensory integration or sensory treatment, that they're doing it in an evidence-based practice manner, which means they've done an assessment, they've picked a goal, they've developed a criteria for the goal.
Measuring it.
They're measuring it, taking data, and they're seeing if it is effective for your child. Handwriting Without Tears is another, it's a printing program that's really, it's in most of our schools. The evidence, again, is not the best quality evidence. There are other programs that have better evidence, especially for kids with ASD. Handwriting, print and handwriting cursive is one that comes out of the U.S. And again, that's...
Is cursive still being taught?
In some places.
Really?
Yes. So again, this is where it becomes really difficult for parents to know what to expect and to know, is the professional who's working with my child doing the best thing?
Right.
Because it means that everyone has to stay current. You have to
Right.
stay current on the science out there. You have to stay current on what you're doing. But if you follow an evidence-based practice approach, meaning that you're taking your data and you're analyzing it, it really then comes down to, does it work for that child?
Well, I was going to call you on it when you said there's not a lot of evidence behind these marketed programs. We're putting it up on a slide, but it really is about the approach and not so much when some of these places, because we know there isn't a lot of evidence with OTs because of the lack of access. That said, you said there was 1,000 ABA professionals in Ontario. I got to assume, clicking on this link for the College of Occupational Therapists of Ontario, there's going to be a lot more.
There's a lot more.
Right.
Yeah. What there isn't, though, is a lot of pediatric occupational therapists.
Interesting.
Because most occupational therapists work in rehab for adults for acquired brain injury, traumatic brain injury, car accidents, sports injury, like all of those things with adults and not so much with children. So it is more difficult to find pediatric occupational therapists.
Okay. And I'm assuming even more difficult to find those with experience with those on the spectrum, and does that even matter?
It does matter.
Okay.
So for any professional, if you're regulated or if you have a credential, it means that you have a scope of practice.
Right.
And the scope of practice is your curriculum. It's what you learned in school. It's what you've been trained to do. But to be effective, you need competencies. And your scope of competency is what's important for your outcomes. And so your competency means how many years have you been doing this with this particular individual, with this diagnosis? How many years, how many types of children have you treated, and have you been supervised and mentored during that time? So have you become an expert in that area? So really we tell parents the general definition of competence is 5 years under mentorship.
Okay.
So you don't, it's tough because sometimes you're finding brand new graduates and they're the only ones that are available to take your child, but they may have scope of practice, but they don't have competency. And it will factor into your outcomes.
Okay. I've got a question here, which I think you can answer. We can go back to what you just said, but my friend's son loves his weighted blanket, I believe, as it decreases his anxiety. I'm thinking of purchasing a blanket for my son. Should I first consult an OT before doing so?
You could consult an OT. Again, there's been, from all the evidence I've looked at, and I try to keep up as much as possible on the research, it's really difficult. There are hundreds and hundreds of articles a week now coming out. But to date, there is no evidence of the effectiveness of a weighted blanket. Saying that, at the time, for a specific purpose, it may be very helpful.
Right.
So what you want to do is kind of do your own experiment. You know, really as a parent, there's no real harm in a weighted blanket. So as a professional, I'd say, look, if your child is having sleep problems, and if that helps them to sleep, and you've got some data to say, look, with this weighted blanket, they're sleeping an hour more, or they go to sleep much faster, then I would say you go for it.
Yeah.
You know, because I can tell you, when I go to the dentist and I have those x-rays every once in a while, and they put that really weighted blanket on you, that lead vest, it calms you down right away, but it's at that time only. Right? There's no lasting effects from that. So if it's there to help a child sleep and they're using it during sleep, amazing if it works. But it's not going to decrease anxiety when it's not in use. Right? So it's, again, it's being kind of like that scientist about it.
Yeah. And I guess it also comes down to, I mean, if you're going to, you know, you don't want to be, because there is no evidence, you've got so many dollars that you can spend, is that, you know, is that a wise use of it when you could be using it for something else? Talking about dollars, what should an OT cost in this province? So
this fee schedule is suggested by the Canadian Occupational Therapy Association, and they suggest that occupational therapists, the per hour amount ranges from $75 to $250 an hour. And the occupational therapy assistant then would range from $20 to $100 an hour. And again, they may have additional charges for your charting time, your mileage, travel time, and medical legal reports will be another thing you see, or court attendance often. And those fees can be much higher than $250 an hour.
Okay. We're going to move on now to speech pathology. So I think most people probably have an idea of this, but this is part of your background and your training. What is speech pathology? What is its role in ASD?
So speech pathology is a scientific field as well, and it is a field where we treat speech, language, and communication disorders, as well as swallowing disorders, voice, fluency disorders, and there is a body of evidence in speech pathology for the treatment of children with ASD.
Okay.
Yeah, so one caveat in Ontario that's different from the rest of North America is that speech and language pathologists in Ontario do not have the ability to diagnose speech and language disorders.
Okay, they have to be diagnosed somewhere else
by
and
a
then
physician
referred.
or psychologist.
Okay.
We can treat them, we can assess and red flag speech and language disorders, but we can't actually give you a diagnosis.
Okay.
And that is very unusual for our field. It happened when our college came into being, and we've been trying to change it ever since, but not really lucky in that regard.
How does one get to see you without the diagnosis?
Parents are really generally pretty accurate with either a gut feeling that something is wrong, or the physician has sent them.
Right.
You know, or a psychologist in the psychological report has said you need to get a speech and language pathologist or see one. You can self-refer. You don't need a diagnosis anyway to see.
Oh, you don't?
No, not to see any of these individuals. Do you need a diagnosis?
Interesting.
Yeah.
But once again, it is, you mentioned the board, I mean, it is credentialed. It's credentialed.
We have a regulated health college, so it's a College of Speech-Language Pathologists of Ontario, Speech-Language Pathology and Audiology of Ontario. They're master's level clinicians, again, school plus supervised practice, plus an exam. There also are an assistant level in Ontario called Communicative Disorders Assistants, or CDAs, which is a one-year college program, or speech and language assistants, who can be trained on the job.
Right.
And they are being delegated by the speech pathologist specific tasks that they're competent to provide, and they should also be supervised. Currently in Ontario, there are no strict supervisory regulations, but it is up to the overseeing speech pathologist to determine that. But I would argue again that the outcomes really depend on that clinician level person understanding how the client is doing.
Okay.
And so they should be doing it pretty regularly.
Okay. And it generally, what does it look like? Is it generally a one-on-one, or is it the same?
Same. One-on-one, group, large group, small group.
Well, most of these things, like the way I guess initially had learned or had been introduced, they all seemed one-on-one at one point in time. Is that just because that's how they were most often implemented, or?
I think one-on-one is most often easiest because, I mean, you don't have to wait to make a group, right? You don't have to get like clients or like children to make the cohesive group. In Ontario previously, insurance is usually one-on-one, although there are groups. Insurance extended health benefits will cover speech pathology or delivered through a group. ABA just recently were we allowed to do small group and large group ABA services. Those were initially in the Ontario Autism Program, only one-on-one was reimbursed or actually funded. And so I think what we're seeing too is some shifts in fields, right? As we get science and we get new studies, we see that working with someone one-on-one has to transition to something else.
Right.
That often to see a lasting behavior change, whether it's a speech and language problem or a motor problem, you have to be able to use it in other kind of venues and other environments with other people, or it's not really beneficial. So sometimes you get your best learning in a group.
Yeah, makes sense.
And again, it depends on that individual child.
And some of the common programs that our parents will be hearing about, we've got listed out here. What do these do?
So some of them, and again, the ones with asterisks have emerging research or emerging evidence, not as strong as some of the others. So the Hannon More Than Words program is like a parent mediator, parent training program. Our Early Start Denver model is a marriage of SLP, speech pathology, and ABA. And so it's an early intervention, naturalistic developmental behavioral intervention.
When you say naturalistic, what does that mean?
Play-based.
Okay.
Looks more like play.
Okay.
It follows developmental trajectories, and it's more intensive. Augmentative and alternative communication is when you're having trouble communicating via speech, and so you're going to, the clinician is going to look at would sign language be more appropriate? Would pictures be more appropriate? Would a voice output or a speech generating device be more appropriate for you? It's best determined, all of that, by an assessment.
Right.
Currently, the only AAC system that has any empirical support for children with ASD, and we're today just talking about ASD, autism, because if we were talking about general speech and language or ABA, this would look different, but for ASD, the picture exchange communication system is the only current system that has enough evidence to be recommended. LIDCOM is a fluency program. Sometimes there's children with autism that also have stuttering. So it's an ABA and an SLP-based program. Prompts for restructuring oral, muscular, phonetic targets, which is a specific manualized program, is often requested by parents for children with ASD. It does not have evidence currently with children with ASD, and it has, I know that there's some studies going on right now. You have to be credentialed in that, and there's been a lot of misinformation about how many children with ASD have apraxia, which is a motor planning problem, and that's what PROMPT is made for. And currently, the latest research I was reading say that less than 12% of children with autism actually have apraxia, and you require speaking. You require phrase speech to diagnose apraxia. So I think if a child isn't speaking, then it's often said that the child has apraxia, which is not an accurate diagnosis. We don't know why at that point, what the actual barrier is. And talk tools are some mechanical tools that you can use to aid in the proper placement of your articulator, so your tongue, your teeth, your jaw, your lips, to help perhaps speech. And again, it doesn't have a lot of evidence right now for children with autism. They are working on that. It may very well work for some children and not for others. Again, if you're doing that evidence-based practice process, you'll be fine. If you're using any of these, you'll know if the outcome is effective. And
as a reminder, the National Clearinghouse of Autism Evidence and Practice is a place that you can go when you're being introduced to these ideas or a program to see what the data indicates, and you can be an informed consumer, which is part of what it is we're talking about today. How is it delivered? How is speech?
So speech, again, is delivered the very same way that ABA is delivered. It can be one-to-one, it can be in very small groups, and it can be in larger groups, can be in home or center-based. In schools, we know there's speech and language therapy in schools, same with occupational therapy. Again, you're looking for a developmental sequence to targets. You want the gaps filled in and those foundational skills so that you could keep building on skills and that the child moves up in progression. It also is a mediator model. Like I said, the Hannon is a mediator model. So the speech pathologist can train the parent or caregivers or help the paraprofessional or the educational assistant at school gain skills to teach that child. So it very much lends itself to all of that.
And there's a college, it's regulated, so finding one is, I guess, easy. On the website here, there are more speech pathologists than there are OTs, or there is?
Yeah,
okay.
there's a large number of speech pathologists in Ontario, and a large
pediatric.
Okay. Again, you want to make sure that they have competency with autism,
right.
that they've actually got experience with that.
And what are we talking about from a cost perspective?
So the fee range for speech pathology is a little more expensive than some of the others.
Yeah.
And this fee, these fees were recommended by the Ontario Speech, Language and Hearing Association, which is a provincial association.
Yep.
And they're recommending, currently the 2019 fee guidelines are that it's $203 an hour. And your CDA or speech assistant is $138 an hour. And again, additional charges may occur. So really, when you're looking at using these professionals, it doesn't take long to go through a significant amount of money for any of these services.
Sounds like. So that leads to a question, and then I'm going to extrapolate after you answer. It's a specific question from a parent, but I'm going to extrapolate after that. 6 hours sounds like due to funding and access to that. Is 6 hours per week in EIBI beneficial for a 3-year-old?
It wouldn't typically be recommended.
Okay.
More hours would be recommended. In fact, a lot of centers will have a minimum amount of IBI or behavior services they recommend, only because you require intensity to make progress.
Right.
And so you want repetition every day. You want sufficient number of what we call trials or practice on targets. You know, our frontline therapists, we look for in a 3-hour session of hundreds and hundreds of practice targets.
Right.
And even in a 1-hour speech session, we're looking at, you know, that's 60 minutes. 60 minutes, like each minute, you can do a lot of practice in a minute.
Right.
So you're looking at hundreds of opportunities in a 1-hour speech therapy session because you need that intensity. So a lot of centers typically, ethically won't take an individual for 6 hours when 25 or 30 hours would be recommended, because then it's going to be really difficult to make progress. You're going to require 2 hours of supervision for that 6 hours of direct service. Yeah. And really, you're only going to meet a couple goals in that 6 hours, if you meet them at all. And so it sounds harsh sometimes.
And we're dealing with a very challenging topic here, right? Like, and I know that what we're trying to do is help parents make the informed decisions, but if 6 hours is what they can afford, focused at 6?
It would be focused, for sure. It would be focused. The other thing that you could do is see parent training. Right. So use your parent training, get trained up so that you're also implementing whatever that is and reinforcing it and generalizing it to your natural environment. So you may be able to get more bang for your buck and for the hours and still see some outcomes. There are research studies, though, that show that that isn't as effective than actually, you know, getting the services by the credentialed people.
Okay, so we've talked a lot about individuals, and there's a lot of similarities between all three of these different practice groups, but you've got a sort of a process here that no matter what type of service provider people are looking for, that this is a process that they should follow. So I should warn you, we have about 7 minutes left, so we want to get through this, and if you guys have any questions, we'll try and squeeze those in at the end as well. But as you well know, we very often don't get to all your questions, and we always try and get you answers one way or another, and we will continue to try and do that today. So let's go through this. What do I look for in a service provider? Right.
So what there isn't for autism services is not a consumer report.
Right.
Where you can open it up like the car issue and see which one for my cost, which one do I buy. So what I've tried to do is go through the process that like consumers reports would go through when they're rating TVs, cars, whatever. So number one, you need to check that the person you're hiring is credentialed, that they're registered somewhere, that they're in good standing. And that's with the occupational therapy and speech pathology, that's all available on the college websites.
Right.
It's also available on the BACB website that you have the URL. That if you request their CV or their resume, that they give it to you.
Okay.
Because we are obligated as professionals to do that. Because you're going to have to do the due diligence
Right.
to make sure this person is who they say.
Right.
You want a contract. And in most ethical and professional guidelines, it needs to be a written contract that you go through with the provider.
Right.
So it lists out your fees, what exactly you're signing up for, what you'll receive, and where and how to lodge a complaint. We don't like to talk about that there are not, that there are problems sometimes.
Yeah.
Sometimes it's just a fit, and if it's a good provider, they will understand that.
Yeah.
But sometimes there's a real problem, and there needs to be a complaint process so that that family has an avenue to go.
A recourse.
A recourse, yes. You need consent forms. So all of these professions are regulated professions in one way or another. So you need to sign a consent for assessment. You need to sign consents for treatment. You need to have information provided to you that says, look, this has this much evidence, this doesn't, this is how we're going to do it. You need to be part of that team in that discussion, but you absolutely need to know, you should know what your child is going to be receiving.
Okay. And of course, we have to do an assessment.
You have to do the assessment, so every professional is beholden to do an assessment prior to setting goals.
Yeah.
That is part of their practice guidelines. So you want to see that assessment.
Yeah.
You should be able to see it. You should be a partner in the goal setting, because it really does, there are factors at home that some goals will be more of a priority than others, and you need to be heard in that. And so the goals also need to be very well written, so that they are SMART goals, that they're measurable, attainable, there's a criteria that everyone knows when the goal is met and not. You need to know that the clinician is practicing as per their regulation, that they're choosing the best scientific methods possible.
It's got to be a hard one.
It is a very hard one, and that's why we've provided all of that, those other things, those other websites
Yes.
to go to see. And that's where competency comes in.
Right.
If you've spent 5 years working with a population, then you should be up on the evidence in that field.
Right.
And so you want to look at that. There needs to be data. So all professionals should be taking data, because that's the only thing that tells you whether it's working or not.
Right.
That data needs to be reviewed on an ongoing basis. And then there need to be timely changes. So in about 9 to 13 hours, no matter the profession, no matter the treatment, you should start to see some progress. And so if you're not, it's not about let's wait 6 months, let's wait a year. And I've seen that, I've heard that. No, there needs to be real change quite quickly, or something's not working. And so you want to be on top of that as a parent. You need to be demanding. I know it's difficult. I've been on that side.
Yeah. Yes.
And it's hard to ask, well, why are you doing this? What are you doing? How is it going? Can I see your data or graphs? Or I'm not happy with the progress. But you need to do that. You need to be able to watch the sessions so that you're trained, that you see what's going on. You can request to review all of it. You're paying for it, you own it.
Right.
And then collaboration. Autism is complex.
Yes.
So when there's a complex disorder, the best service is when you have a team. And because no one profession has all the scope of practice to treat all of the targets.
Right.
So if you can collaborate, and certainly if the person doesn't have scope of practice in an area, they are obligated to call in another professional and get help. That would give you the best outcomes when there's really collaborative practice.
Okay. And the last steps?
So I've already said this, you should be part of the treatment team. You also want to check that your treatment team are getting continuing education, that they're staying up. Things change. These are scientific fields. When there's new evidence, we should be switching. And so you want to do that. And then supervision is the most important one. And it's the one that sometimes I see that doesn't occur enough, is that you have a frontline therapist who's not being supervised, because parents are often feeling that's all I can afford. This is, this person says they're an ABA therapist, they can do it. Or you have a speech assistant or an occupational therapy assistant that isn't getting really regular supervision. Then you've delegated an entire field that's required a master's level down to people who don't have that.
Yeah.
Right? So it would be like the I don't know, like the surgeon that just sutures you up at the end,
Yeah.
actually doing the whole surgery. And,
Yeah.
you know, the heart surgeon actually didn't step in when they needed to.
Right.
So you really want to make sure that that supervisory level, that person is really in touch with the program, knows your child, is there for you to answer questions and to problem solve when needed.
Okay. I'm going to take one more audience question, give you a chance to wrap up, and we will finish on time. Most ABA providers I've approached have asked for a commitment of a certain number of hours per week before assessing my child. This doesn't seem right, is it?
So often what they will do is they'll sign you up because what they're thinking is that either they have a minimum number that they will take in their center. We take 9,
Okay.
is 3-hour sessions. Some providers will take more, but really that number shouldn't be firmed up. You should have a way of getting out or changing if the assessment shows that you need either less or more.
Okay.
The behavior analyst really needs to behave professionally and ethically, and if they are, they're going to recommend the number of hours that are required. No different than a oncologist recommending your chemo treatment regime. They're not going to recommend something that's not going to be effective.
Right.
They recommend no less than you need and no more than you need, and so that's what you're needing to look at. Again, if they're thinking they're bringing your child in ABA, it's a team, so they need to put your team together. They're holding people's time. They may be holding a schedule in their center.
Yeah.
And so it's complex. The complexity, I think, would astound some people about.
Yeah.
It really is difficult.
Right.
To organize, and so I think parents, yes, it's your child and your child comes first, and we understand that, but it also has to work within the service provider's business.
And, you know, this minimum, we don't know what it is, but it may just be simply that anything less than that minimum
Right.
is not going to be not going to be effective.
Yes.
Before we go, is there anything that we didn't touch on today that you want to ensure our audience hears? Any message?
Any message? I think the message is really, you know, do your due diligence,
Right.
ask questions, know that you have the right to ask questions.
Yeah.
That if you don't think you're getting the right service, it's fine to go get second opinions. We have that routinely in speech pathology and behavior analysis as well. A good provider would be happy to talk to you and walk you through things, and certainly Autism Ontario, the navigators have been phenomenal. I know I've spoken to a lot of parents who have said that that's been a really valuable service for them.
Excellent, excellent. Well, as far as, you know, getting the information, there is, I'm just going to bump to the end for our producers here to see it, there is a bunch of stuff we didn't get to from an FAQ perspective and a glossary and a bunch of information at the end. Plus, as I mentioned before, the Resource Center is stacked. So before leaving today, download the slides. You'll get all of this stuff as well as the other items that I referenced, because there's a lot of good stuff in there. We dealt with something today, something that has going to come up more and more often. This is the disconnect sometimes between the budget and now the services that are required. And one thing that you can do is let other people know about these events right here. And that is by letting them know that this presentation, if you found it informative, will be archived and available on learning.autismontario.com or the Autism Ontario website. They can come here and they can watch it. The more people through this program, the more awareness that we help create at Autism Ontario, the more funding we get and the more funding the program is going to get. So it's better that more people know about these things than not, and help with that, that somber moment we had about the individual with the $5,000 and unable to. With that, again, this is going to be archived tomorrow. Anyone is open to see it. We want to thank our esteemed presenter today. That was a jam-packed presentation. I feel like it might have been, like our survey course, and we need to dive into it again sometime soon. Thanks, as always, for your time and your participation, and we look forward to seeing you at our next Autism Ontario event.